Good afternoon, everyone, and welcome to this afternoon's session, Reimagining Long Term Care, Lessons from COVID-19 and Beyond. My name is Samantha Peck. I'm the Executive Director of Family Councils Ontario, and it is my pleasure to welcome you to this afternoon's session, originally held on June 17th, 2020. Before we get started, just a few things we want to mention. We meet on Indigenous land across Ontario. These lands have been taken care of and are the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis. The territory is part of what's called the Dish with One Spoon Treaty, and that's an agreement between the Anishinaabe, Haudenosaunee, and allied nations to peaceably share and care for the resources around the Great Lakes. This territory is also covered by the Upper Canada Treaties. Today, Toronto and communities across Ontario are home to Indigenous people, and we are so grateful to have the opportunity to meet and work on this territory. We're going to pause at the moment, and I am going to pass over presenter to this afternoon's guest speaker, Jacqueline Choiniere, who will introduce herself and take over the session. So just bear with us for one moment while we get our presenter set up.
Thank you, Samantha. Thank you, Samantha.
Okay. You're welcome, Jacqueline. Yeah, there you go. Perfect.
Okay, I think, am I on yet?
You are. Take it away.
Thanks ever so much. I appreciate, first of all, the land acknowledgement. Thank you for that. Hello, everyone. I'm Jacqueline Choiniere. I'm part of the Reimagining Long Term Care team. I am one of the co-investigators. And in the rest of my life, part of the rest of my life, I am a faculty member, associate professor in the School of Nursing at York University, also the graduate program director. This long-term care research that we've been involved in, and I'll talk more about my colleagues, the other co-investigators that are involved. This is a research initiative that we've been engaged in since 2010, when we first came together to talk about why we needed to do this research. And it has been probably the most profound research experience I've had during my academic career. So I am very happy to be here today to talk to you about some of the promising practices we have found, and then also to speak about the implications for COVID-19 and beyond, which is something on all of our minds, I'm sure. And I also need to say that this research was funded by Social Science and Humanities Research Council of Canada, also known as SSHRC, and Dr. Pat Armstrong is the principal investigator on this team. Okay, so this is my outline for today. I do want to talk about the background, as I said, what got us involved and why we felt compelled to engage in this research. What were the objectives and assumptions that we came to this research with? What were the themes and the methods by which we gathered our data and made our observations? I want to then speak to some of the key promising practices that we found, and this isn't in any way an exhaustive list of the promising practices that we found, but it is an important list, some of the dominant ones. And then I want to get to lessons for COVID and beyond, and of course, happy to take your questions at the end. So, speaking of the objectives and assumptions that led us into this, one of the key central contexts for us was this WHO definition. A society that treats its most vulnerable members with compassion is a more just and caring society for all. And that very much informed the work that we had done. We had, from the beginning, felt that this was a sector that was in need of attention and study and in need of improvements. And another assumption that we shared is that long-term residential care is going to continue. Our need for long-term residential care is going to continue for the most vulnerable among us. I know that there is certainly a lot of conversation about the desire for more home care, and we don't see that as a mutually exclusive situation. We do believe there is a need for much better and improved home care, but there will always be a need for a number of reasons for long-term residential care. Also, it's a workplace for thousands of paid and unpaid providers, mostly women, and many from racialized communities. We very much wanted to, certainly in academia and in research, one of the tendencies, certainly if one is researching from a critical perspective, is to look at some of the problems. But we wanted to turn that a bit on its head and seek promising practices. We felt that it was really important for us to do that, to focus in as soon as we could on what was good and what was promising and how we could then incorporate that more broadly. We sought, and I'll again explain the team and the widespread and large cross-section of team members. But we did seek to share international lessons with different eyes. And this is also an important concept, the idea of different eyes. And I will explain that a little more as well. But certainly that it reflected our different contexts, where we were from, what our perspectives were, and how we shared those perspectives with one another. Conditions of work are the conditions of care, also something that was really critical to us, and that care is a relationship. This is such an important concept to us, and again, I will get into more explanation about it as we go along, but what we're talking about here is more than simply a friendly smile. What we're talking about here is how the quality of care is so heavily reliant on knowing the patient, knowing other members of the team with whom we work. And it's such a critical part of delivering good care. And of course, the promising practices in particular that we were seeking were those that treat both providers and residents with dignity and respect. Again, that understand care as a relationship, that take differences and equity into account, and that promote active and healthy aging. So, our team, there were 26 co-investigators, and this represented 12 disciplines in 6 countries. Now, the 6 countries were, in addition to Canada, the US, the UK, Germany, Sweden, and Norway. And the disciplines, there were the usual suspects, so to speak. There were social scientists and nurses and physicians, and social workers. But we also had historians, architects, economists. So it was truly a broad cross-section of experience and expertise that we brought to bear on this research. And of course, our research team was divided into 4 different themes that essentially structured our approach and what we were looking at when we were in these places. Approaches to care, work organization, accountability, and financing and ownership. And of course, I need to say that we had other partners as well involved, 5 union partners, 2 employer association partners, postdocs and graduate students, and certainly closely engaged with community and advocacy groups. So, how did we do what we did in order to find what we found? We approached these because we really did want to get into these nursing homes in these various countries and see what we needed to see. So we employed a rapid ethnography approach. So many of you online may know about ethnography, but this is essentially the idea that you need to get in and observe what was going on, take copious notes about what was going on, what we witnessed about the relationships, about people engaging, about what they were doing and when they were doing it, and so on. Certainly we needed to look at, prior to that, we also did significant review of the documentation, such as organizational charts and other key pieces of documentation from these nursing homes. And these are the places that we went into homes: Ontario, Nova Scotia, British Columbia, and Manitoba in Canada, Texas in the US, and England, Germany, Norway, and Sweden, as I said before. And the way we approached it, in each visit, there was a team from home and a team from away. And we certainly mixed the way in which we were paired on these, within these long-term care homes. We visited in each place one main long-term care residence, and we were there for 3 shifts over between 4 and 5 days, and over all 3 shifts. And we did copious observations and interviews and votes, both. So I'm moving on to some of the key promising practices that we identified. Dining and food. Certainly food was something that we knew was important from the get-go, and that proved itself true. And one of the very important promising practices that we observed was when the food was cooked, not only on site, but in the unit. I mean, you can imagine when the resident is able to hear and smell the food being prepared, it does so much to increase appetite, and also understanding and that knowledge about where the food, how the food is being prepared, and that it's there and you can see it all being done. And certainly we saw that in Sweden and Norway and Germany. The use of local ingredients when possible, and seasonal, and that made such a difference. And we saw that in Canada, the US, and Norway. Resident participation in food prep. And this was, and I'll never forget, this was one of the a very strong memory I have walking into this unit in Germany, and I could see residents preparing. There was one individual who was cutting peppers. There was pizza being prepared that evening for the supper. This was the late afternoon meal. And the one resident was cutting peppers and onions, another resident was setting the table, and yet a third resident third resident was pouring glasses of wine, and a fourth resident was emptying the dishwasher. So it was a really incredible sight and experience to see that level of participation. Flexible eating time, something else that we certainly saw as promising, and also seating places, flexibility in seating places, and we saw that residents able to come in when they were hungry and sit with, if there was another resident there they wished to sit with, that was fine too. They didn't have to sit in the same place all the time. The idea of sample plates, we saw this in Canada as well as other jurisdictions, which means that, sometimes when you make the choice of what you want to eat 3 days in advance, it doesn't always turn into being what you truly want that day. So we found it was promising when staff would carry around plates that were available and options for the residents so they could choose what they wanted that day. And also smaller bites. And I have a a picture of this one that we one of the homes we were in the UK, and they had found that some of their residents were turned off when there was a large pile of food, for lack of a better word, in front of them, a large plate of food that they found. There was residents ate better and more when they had these choices of small bites, when they could essentially eat at their own speed. And that was a really important, promising practice.
Jacqueline, I'm just going to interrupt you for a sec. We're seeing that there's some audio issues on your end. People are having some hard time hearing you. Are you on your phone or using your computer?
No, I'm using my computer.
Okay. Okay. So we're hearing some people saying they can hear fine and others aren't. So if you're having an issue, attendees, maybe try just turning down your audio a bit, as Jacqueline is running her session from her computer. So appreciate your patience. Just want to check in. Thanks, Jacqueline.
Sure. Is it? I don't know. Should I turn my sound down a bit, or is it?
That might help.
Okay. Is that any better? Is that better?
It's better for me. I don't know if anyone else is still having some challenges.
Okay.
Okay.
Okay, I'll proceed. Let me know if there's anything else now. So I talked about the example in Germany about the residents being involved in meal preparation, and the entire team working together was the other part of this. And there was also a promising practice that we noted in BC. And here, because there was no contract staff used in this one home that we were in, there was this deep knowledge of residents. And residents also were given a sufficient time to eat, and there was food available for them 24 hours a day as they wanted it, as they needed it. Is my sound better?
Unmuted.
Yeah, if you're using an external speaker, you may just want to move it away from your computer a little bit.
No, I'm not, though. I'm not using an external speaker. I'm just using I can hear something. It sounds like there's something going on in the background. Am I the only one unmuted?
Yes.
Okay. Sorry, my apologies. Okay, the other thing that we found that was particularly a particularly important, promising practice was integration with the community. Those places in which the home was certainly a part of the community and a strong part of the community demonstrated as being quite promising as well. And integration with other services. And we saw that in 3 different countries, Canada, the US, and Sweden, where there was some places in Canada, where there was a smooth transition from one level of care to another. Another aspect of integration with the community we saw in Norway, a cafeteria that was in which older people from the community would come in and able to get an inexpensive, nutritious meal, but also socialize while eating. And in Germany, similarly, a nursing home regularly opens its doors to community members for meals at cost and for special celebrations and parties. The one home that we visited in Germany, we happened to be there during a national holiday, and so there were lovely celebrations in which members of the community were involved. And so this is an example in Norway. The actual nursing home was attached to a community center. And there were, for example, there was a daycare, there was a cinema, an Olympic-sized swimming pool, and what we found and observed was that this type of contact, of connection, actually seemed to increase the visits that residents in nursing homes would parents would come to visit their parents or their parent and would bring their children along and drop them off at the pool or at the cinema, and then have a visit. And then the grandchildren could also come in later. The idea of having a modern, spacious building with lots of art and stimulating colors, that was the case in Norway as well. And rooms with doors that opened onto an enclosed garden. So there was the safety aspect being taken care of, but and also the ability for residents to walk out and enjoy the outside. Another promising practice that we found was a more flexible division of labor among those who provided care for nursing home residents. And we saw several examples of that. In one of the nursing homes we visited in, actually this one was in Texas, each of the senior managers was responsible for connecting with a specific list of residents. So there was a concerted effort for members of the administration not to be completely separated from those in the nursing home, but that they would also visit them and visit the residents and become aware of some of the issues that were happening with them and so on. We saw weekly team meetings and entire team meetings to assess and talk about resident needs in Sweden and in the US. We also noted another promising practice was when staff were able to make certain decisions about care. And that was a particularly promising practice. For example, when it came to food, and in the situation where you have staff who really know deeply a resident's practices and likes and dislikes, that made such a difference. Or knew when and this individual wanted to eat, or if an individual, for example, someone with dementia, how they liked to be awakened, and if staff, once they knew that, they could, whether someone wanted to be awakened slowly, and if, of course, there was time to do that, etc. And I'll talk about staff complement shortly, but that it was particularly important when staff could make that decision, when they weren't so confined on a very tight schedule that they weren't able to make those decisions. And also, so we saw flexible divisions of labor in Germany, Sweden, Norway, and the UK, and I'll provide some specific examples. The one place that we went to in the UK, there was no strict division of labor at all. The expectation was that everyone, from the registered nurse to other practitioners, would all pitch in as needed. No uniforms. There was a great amount of flexibility when it came to breakfast and bedtime. Staff initiative was encouraged. There was a frequent spontaneous activities we noticed, and as in not only the planned activities, but they were spontaneous activities. Certainly song and music was one of those spontaneous activities that we noted. In Germany as well, also a limited division of labor. Care was organized around a common and a shared unit, and that was a particularly important structural or physical environment promising practice. There was one responsible caregiver always in the living space, and usually these units had be around somewhere between 8 and 12 residents. And of course, which I'll get into more, adequate staff. In Nova Scotia, for example, we encountered a new role, and this was a role that integrated a little bit of what a PSW, as we would know a PSW here in Ontario, would do, with some light housekeeping duties. So this individual was there in the morning when the resident got up. And when they got up, they came out into the main room, which was on the unit, which was where they would eat. This individual would greet the residents, and she knew what the residents liked to eat. There was an amount of food actually on the site that she could give them something before the kitchen came up with the main breakfast. So if, for example, a resident wanted a piece of toast or a muffin or even a boiled egg, she could do that, and she would. In addition to serving breakfast, she would ensure that the rooms were just tidy. This individual didn't do the major cleaning, but just sort of the tidying up and making sure the bathroom was tidy after, if the resident had showered, and also did wash some delicates. And so this was we found quite promising in the way so many of these skilled jobs, this knowledge and skill of the resident and residents' needs, were combined into this one role. Again, flexible. Another promising practice that I've mentioned already is the idea of care as a relationship. And certainly, in order for this promising practice to be realized, it needs adequate staff and an appropriate staff mix. Certainly need individuals with all of the skills and abilities that are required, including the knowledge of the resident, and enough individuals. And certainly the idea of working in teams was something that we found to be extremely positive. It requires a stable workforce, and certainly there is a link, the idea of full-time staff, the idea of adequate hours of care per resident day. And certainly we noticed that link with ownership. We did find that there was higher staff complements when it came to not-for-profit homes. Treating care as a relationship requires time. And certainly we know that the acuity, the complexity of those in long-term residential care has increased quite dramatically, and more care is needed. And thus more time is needed. And we would also say that it requires standards, effectively enforced standards. But we have been wary of some standardization, and I will give you an example of that shortly. Care as a relationship also requires appropriate training and ongoing education. And certainly I'll get to this later, but it is something that became very clear in COVID, that there needed to be better training ongoing about what the expectations around this particular infectious disease, this pandemic, was. It requires appropriate working conditions. For example, this one of the homes that we ventured into in Germany had quite high staffing numbers. They had implemented an apprenticeship program for workers who were caregivers who were making their life long-term residential care, and they pulled them in an apprenticeship type program in combination with education outside of the setting. And there were quite large numbers of them, and this certainly was reflected in the quality of care that we witnessed. And it certainly means requires an integrated system. This again is something that we saw in Norway and Germany, and it means tolerating some risks. This was an issue that we certainly had many discussions about. This notion of what it means to individuals, residents who are in a situation where no risk is tolerated. For example, if they are placed in a wheelchair, which is always often for their quote own protection, but that really did have a significant impact on their ability to enjoy, to move around, etc. Being able to venture outside. There were a number of ways in which it became clear to us that some risks needed to be tolerated. An example is when it comes to food. There was one experience that our team members had this was in BC, with a resident who had an underlying heart condition, a cardiac condition. So the idea was he shouldn't eat salt as a result of this heart condition. However, this man was an Asian individual and an Asian Canadian, and had been eating salt all of his life, and soy sauce and so on. And then the decision was made there that because he wasn't enjoying his food without it, so it was far better to let him have salt in this situation, even though arguably it did pose some additional risk, but at least he was eating and he was enjoying his food. Organization and funding is another area in which we found promising practices. The for-profit and not-for-profit debate, and certainly we have encountered here in Ontario a pressure and a move towards more for-profit ownership, as well as managerial strategies. And there is growing evidence that care is better when profit motive is removed. Certainly we have members of our research team who have studied that in more detail, and there are a couple of references actually included in the bibliography I have at the end of this presentation. As far as regulation and trust is concerned, we see that as as two ends of the same coin. How regulated one is. A continuum is the word I'm searching for, actually. Continuum between regulation and trust. And accordingly, we found that standards rather than standardization were key. And also size matters. We found that a small unit within a larger agency and a single room for sleeping turned out to be much better, much more promising for residents. And they certainly seem to enjoy their experiences there more. And I'll talk a little bit about standards versus standardization. Quality, for example, something we're all certainly concerned about. The difference between those where there is standardization, and there are some examples here in Ontario. So there must be a 21-day menu cycle, getting residents to the dining room at a particular time, a specific number of snacks, dinners not served before 5, full breakfasts until 8:30, and so on. We would argue that a lot of these standardizations do not result in as promising practices as those where there are standards. So compared to more flexible approaches to eating, times and food, able to eat when hungry, flexibility in breakfast times, food always available, and as I've discussed before, resident participation in preparation. So that was a snapshot of some of the key promising practices that we found. And now I want to turn to lessons for COVID-19 and beyond. So certainly, I would argue that the right to care has been, and the structure and organization of how that care should be offered and should be available has received, with reason, a lot of attention over this crisis that we've been through. The importance of universal, publicly funded, accessible care, I would argue, has never been more important. The problems in the fact that long-term care is excluded from a Canada Health Act like standards, like legislation, is problematic. And because of this separation, we would argue that it certainly makes integration more difficult. Certainly the residents' needs are ever more complex. Similar to acute care hospital needs of not that long ago. The first nursing home that I went into for this study, which was back in 2011, I was absolutely struck by the fact that I felt like I had passed through a time warp and gone back to some of my initial education experiences as a young grad and a young student nurse, in going into a hospital, my first hospital experiences, because it felt, it looked, it sounded just like those experiences. So that speaks, among many other things, to the fact that these health needs are much more complex now than they were. And also that governments haven't kept up with the need, haven't kept up in funding for those needs, those changing needs. We also argued that the problems of when managerial practices are taken from the business sector, and here I'm speaking specifically about things like contracting out, the use of part-time or casual workers in order to save costs, and the accountability approaches that are used. For example, in our observations, accountability practices currently seem to focus in specifically on what different workers have to do and what their the demands on them. As an example, I talked about before, having individuals into the dining room at a particular time and so on, rather than things like staffing levels and having adequate staff, which the contradiction in that is quite problematic, that in order to get all these standards, in order to operationalize all these standards, one needs to have adequate staff and adequately prepared staff. So we'd argue that these accountability approaches focus not in the right direction only. Certainly more individuals are in the home, and with the contracting out of laundry, cleaning, and food, that means people are in and out of the home as well, and that has serious implications for infection control. The increase in for-profit care also ignores the evidence. And again, what the evidence does tell us is that not-for-profit care enjoys higher staffing levels, fewer complaints, and fewer hospital transfers than in not-for-profit care. And I'm citing, again, one of our colleagues, Margaret McGregor, in this one. And she has a number of other articles out on this as well. So it does, this ignoring of the evidence suggests a devaluing of older people, and in our perspective, we need to focus on care, not profit. The COVID-19 crisis also reaffirms the following assumptions and the following findings: that the conditions of work are the conditions of care. In order to provide resident-centered care, staff need time. They need support, they need supportive structures, and they need reasonable compensation. And certainly, as never before, the importance of the social determinants of health, those things that really do make us healthy. Good food, the time and the support to eat, the importance of housekeeping, of having a clean environment, of having clean clothes. In general, what we found, one of the phrases that kept coming back to us as we were doing this research all along was the importance of adding life into years and not simply years into life. And we encountered this phrase when we were in Germany, and I think certainly never before has it's become, the importance of it has become accentuated with this COVID-19 situation that we've been going through. Staffing is critical. And certainly this was something that has been emphasized. The reliance on part-time casual workforce is problematic. The ideas of having staff moving between agencies is highly problematic. And individuals were in the situation of having to do that because they couldn't cobble together an adequate income from just one place. So it was something that so many of staff were forced to do. So not only more staff, but staff with greater skills, and once again facing the complex resident needs. Research now suggests that there should be in the area of 4.5 hours of care per resident day, and that's direct care, and it's also hours worked rather than hours paid. In other words, the difference there being that hours worked is actually physically someone there, whereas hours paid could include people who are on vacation or away for leave, etc. And certainly we found that with more staff, staff illness and injury is much less likely. A study that a number of the colleagues on this research project engaged in was a comparison of issues of violence and accidents and injuries in Nordic countries versus Canada. And the Nordic countries had much, much lower incidences of all of these problems. And also, in addition, need for ongoing education and training. There was even, it may sound simple, but something like the donning and doffing of PPE is something that staff needed training for on an ongoing basis, dealing with infectious control. And of course, underlying all this was having adequate staff in order to do that. So the importance of knowing residents' needs in order to meet residents' needs. And it's, again, emphasizes that notion of care as a relationship and needing more full-time, permanent, and permanent part-time. Acknowledge that not all full-time staff would perhaps work given the differences in care and staff needs throughout the day, but then there should be a permanent part-time possibility rather than contract casual staff. Families. Certainly, we've witnessed the limitations of having to rely on families for key aspects of daily care. Families are critical for all sorts of aspects of care to make residents' lives worth living, to put life into years and not simply years into life, and so on. Family and family involvement. Family and however one defines family, significant others and friends and so on, are so critical. But the reliance on these members to provide critical aspects of care was highly problematic, as we did see. So suddenly, given the reality of low staffing levels, it was a dramatic, and illness on the part of staff, it was a dramatic loss when families were unable to visit. And this reliance as well, and the low staffing levels, ignores again the complexity of needs and the skilled nature of the work that goes on in long-term care. And we think we think that is something that's been ignored. It takes an incredible amount of skill in order to know how to encourage someone to eat, to encourage someone to go for a walk, to engage with an individual around all sorts of bodily needs and life needs. That takes a lot of skill, and a good part of that skill is having the time and the ability to know that resident and what that resident's needs are and preferences. The reliance also on paid personal companions who in many cases also work in more than one home. So this also light was cast on the problems in this as well with the COVID-19 situation. BC certainly provided leadership in the way that they handled the COVID-19 crisis there. They raised the wages of the care aides, the healthcare aides, to a union rate. They ensured full-time positions, and they were awarded with having corresponding improvement in infection rates. So it's inadequate. The point here, I think that's very important, it's inadequate to simply prohibit the number of workplaces. There is also important to ensure that staff have an adequate living wage and they're able to make an adequate living wage. As far as equipment and surge capacity, well, we've heard a lot about equipment. Certainly, one thing that's important to note is the rationing of important equipment predates the pandemic, and I would argue goes back to the ways in which the sector has not been adequately funded, adequately supported. And COVID-19 only worsened that situation. Certainly in our research that we noticed where and how these gaps existed. The lessons from SARS were ignored. I was actually working for one of the nursing associations as their policy director when SARS hit. And there was a very comprehensive report that came out post-SARS that had a number of really important recommendations, one of which was the need for healthcare workers to work in only one place and not to be moving from place to place, because this certainly was one of the major issues with SARS. And yet these were ignored. And personal protective equipment continues to be a lower priority for long-term care. It was a lower priority from the get-go, and that should not have happened. And the infection rates as well as the tragic deaths are only a testament to that. This notion of surge capacity is also particularly important. It's possible, surge capacity, would argue, is possible if we build on stable position and adequate protections already. And also the importance of a reduction of mental and physical health risks, that those also are critical if we're going to have surge capacity. Oops, sorry. So, as far as physical environments are concerned, COVID-19 emphasized the importance of the need for single rooms, that there's a problem and when we have 4 or 2 bedrooms even, for infection control, for limiting exposure. The need to decrease transfer from hospitals. The need, certainly during the peak times of the infection, to limit further admissions. The need to repurpose space to allow distancing. And again, if there isn't any surge capacity, there isn't any space to repurpose. Room for staff to change in and out of street clothes. As we know, staff coming in and out of a nursing home carry carry problems, potentially carry infection with them in and also then home to their families, neither of which is at all acceptable. So it is important for there to be these sorts of physical spaces in order for staff to reduce that possibility. Certainly when it comes to new structures, as we move towards, hopefully, when we do get new structures or rebuilt structures, the importance of smaller units. Once again, we found that to be, even if the agency itself was large, that having the smaller living units allowed for that ability to better control what was happening in those who were in it. As I say, somewhere between 8 and 10 or so residents. The access to outdoor space, room to allow for safe food preparation, and also laundry and cleaning. All of those were critical. So, short-term actions going forward from here. We suggest it's important to follow the BC example when it comes to their move on wages, benefits, and staff continuity. Particularly important. Important to provide regular testing for those living and working in nursing homes. Adequate and ongoing training for all working in the sector. I think sometimes, although individuals come to work in a home with initial training, we fail maybe to pay enough attention into the need for ongoing and changes in that training and education as the circumstances change. We need to keep essential regulations. We need standards. Absolutely, we need standards. I think we need standards when it comes to staffing, that we have not seen that. And in fact, staffing assurances, regulations that we did have in the past have been removed. And we need to get back there. We need to get back there based on what the research is telling us is needed. We have to ensure adequate PPE for all of those living and working. We need to limit transfers into the home and again provide separate spaces for staff to change and perhaps even offer alternative housing for staff if the agency is in the throes of a major outbreak. Over the longer term, certainly the need to continue the short-term strategies into the future, to develop a universal public long-term residential care plan that's modeled on the structure and the conditions of the Canada Health Act. We need to develop a long-term labor force strategy. The needs within long-term residential care, the staff needs, and with the sort of the staff type and staff numbers have changed dramatically, and we need to keep up. Stop privatization and move to nonprofit ownership. Stop contracting out food, housekeeping, and laundry once again. And you know, we saw so many examples in which individuals who were part of the housekeeping staff and had important relationships with residents, as well as what we consider to be the direct care staff. Ensure widespread availability of vaccines and/or drugs as they become recommended. Ensure adequate PPE and stockpiling for the future, and move to better integrate and coordinate healthcare across the sectors. And certainly, I think one of a really key and important consideration for us going forward is how we need to develop safe practices by which families can stay in contact, can retain that very close contact with their loved ones. And we need to be able to do that in a safe way for all concerned. And so that's it. I just want to leave you with a couple of slides here. This shows a picture of some of the publications from our research team. upper right are the booklets that we have that are actually available for downloading free. And the others are just a sampling of our publications. And this Creative Teamwork is a book that members of the team we have produced to talk about our methods and how it was that we gathered our promising practices. And this website, www.yorku.ca, RELTC, is available to you, and you can go on and download a number of the booklets and so on I've talked about. And thank you very much for listening, and I'll happily take any questions.
Great. Thank you so much, Jacqueline. This has been very, very informative. At FCO, we're aware this project has been going on for quite some time and are really pleased to see how we can learn from the results to reimagine long-term care and plan for any next waves of the pandemic and others. So we've got quite a few questions that have come in. So on behalf of the attendees, I will start this. So luckily we've got quite a bit of time to delve into this. The first question is a clarification. What does senior management mean? Are we defining that as someone between a director of care and first line team members, or is that being used in a different way?
Well, generally, yes. Generally, we're talking about sort of senior administration, the directors of care. This, I guess, goes back to the slide that talked about senior managers engaging with, having a number of residents with whom they directly engaged. I believe that's maybe where the question comes from. But it was everyone. In this case, in this one home, it was everyone from the CEO to the CFO to the director of care and so on. Every senior administrative person within the agency had a list of residents with whom they connected on a regular basis.
Great. Next couple of questions are around different models of care. So did you see any connection between various models of care and staff satisfaction or turnover?
Yes, certainly. I think, and certainly underlying all of this is that the principle that there needs to be adequate staffing. There needs to be adequate staffing and an adequate mix of staff. As far as models of care were concerned, we certainly found those agencies that engaged in teamwork, that had a more flexible division of labor. So it wasn't just, okay, I am the RPN, I do this, or I am the RN, I do this, and I'm the PSW, I do that. It wasn't simply that approach, but where there was more of a sharing of activities, more of a sharing of the work, and we found that certainly was promising in a number of places. And although of course our main goal in this research was seeking out promising practices, we couldn't help but stumble upon some that weren't so promising. And I'll give you an example. We found in some of the homes that we were in that some of the strict differences, for example, when it came to have the individuals who would prepare the reports or do particular assessments and so on, and then weren't able to participate in any of the let's say more active direct care, that caused some tensions. So certainly that notion of sharing, that notion also placed, I think, the right level of importance on engaging with residents.
That's great.
I've answered that.
Yeah, absolutely. Did you find that those models of care that you mentioned, or those promising practices, could actually be used to prevent staffing shortages as a concern moving forward?
Well, yes, I think, but there has to be the ability and the other staff. So what I mean is that still underlying this, there is a concentration of staff that would be required. Certainly, though, what I will say is when staff are happier in their work environment, when they feel that they are valued, when they feel that their work is important, when they are engaging with other colleagues in a shared environment, a shared work, we're in this together and we'll do it together sort of environment, that increases work satisfaction. We found that increased work satisfaction, and that also makes for greater longevity. It's an important part of the picture. It's part of the picture.
Mm-hmm. Makes a lot of sense. So in the research, how did you determine or how would you define staffing levels as being adequate or quite high? How did you determine this?
Well, the research tells us, right? The research is pretty clear around having the need for, given the current complexity, at least 4.5 hours of care per resident day. We're much lower than that in general. We're probably closer to 4 or just below 4. And that makes an incredible difference. The time to care, right? That is so key. We certainly heard from so many staff members at all levels how important it was to have that time. Again, I go back to an example, and forgive me if I use this already in the talk, but having the time to respond to what a resident wants and needs. That's time. And if you are rushing in order to get everybody into the dining room because there aren't enough of you to do that, and you don't have time, and therefore you need to rush a resident along. And we have a good high concentration, probably in the vicinity of 70% or so of the individual residents in nursing homes now who, in this province anyway, who are suffering a form of dementia. And it's not a good situation when one has to rush someone who's suffering from dementia at all. It takes time to care. It takes time, whether an individual needs to wake up slowly to music. Someone who is a full-time staff member who knows this individual really well knows that, right? So it's not just a question of, okay, this type of worker, I do these 5 skills with this individual. You know what I mean? So it is the entire context. It's about care. Mm-hmm. And it's that notion that care is a relationship.
So speaking of sort of relationships and staffing, were there any models you viewed in the study where staff actually resided in the homes along with residents or in the same campus or community?
I'm thinking that some of the individuals who were, this goes back to an example in Germany, and this was the place that I mentioned relied on, had a very comprehensive program of training and apprentices and so on. And they lived not far away, not within the actual same space that the residents lived, but they were in a neighboring building. Excuse me, just for a second. They were in a neighboring building as they were going through school, etc. Mm-hmm. And so they were close. And some of them would visit even on their off time. So there was quite a close relationship.
Mm-hmm.
Yeah. So.
Well, it's interesting to see that how different jurisdictions have looked at connecting the staff with the residents and really building those all important relationships. Did you come across any research or data that provides evidence of what's actually physically possible to accomplish in the tasks that PSWs are required to do in a given amount of time? For example, if we're looking at 4.5 hours of direct care, is there any evidence as to what is actually possible to accomplish in that time?
Well, the idea the idea is that's the time that's needed to provide more complex residents, and that's all aspects of care. But I think it's rather than specifying the and itemizing the duties, I think it's as much about how they are carried out. And if that's, for example, within a team environment, so there are others who are also around, others with whom the PSW can consult as needed or seek assistance as needed. So as far as itemizing exactly what can be done, no, but the research is pretty compelling. One of our colleagues involved in the research, Charlene Harrington, and she's actually located in the US, but has done an incredible amount of research on the complexity of care and the hours of need. And she is one individual. If you look on our site, you will see some of the articles that Charlene and her and other members of the team have written. That will provide a really good breakdown of why it is that we need at least 4.5 hours per day of care.
Okay, great. So let's move on to national standards. So does your research indicate that we do need national standards for long-term care and across Canada? And if so, how would this benefit residents and staff?
Well, I think it is at minimum, it is important that our residents in long-term care have similar standards around public administration, around funding, around care that is needed, and so on, as we have in the other parts of the sector. I think that's minimum. And I think that there are certainly standards that needed that really do scream at one. And one of those standards is adequate staffing and an adequate staffing mix. I think we talk very much in our research about being careful not to go towards, being careful to stay away from standardization, but maintaining very strong standards. And I think certainly the numbers and type of staff is important. The idea that this is an environment in which lives are lived. It's not simply an environment in which clinical care is given and received. And I think that's particularly important. I think there should be standards around the importance of family engagement, again, as important to the quality of life rather than essential to key aspects of care. And so I think that would be a very strong step in the right direction. Of course, it needs to come equipped with other policies, other considerations as well.
Mm-hmm. So could you talk a little bit more, elaborate on how including long-term care in the Canada Health Act would be...
Sorry, I need to correct that. There's a number of us who are a little concerned about the idea of reopening the Canada Health Act. Okay. What we're talking about is a companion piece of legislation that picks up on the major components, the major principles within the Canada Health Act. but also is more specific to long-term residential care.
So would you be looking at then suggesting not necessarily long-term care in the Canada Health Act, but having similar standards outside of the Act that are specific to long-term care?
Yes, I think that is what we need. We need standards.
So about just looping back to the standards around number of hours of care, whether that's done nationally or provincially, how would you encourage people to, families who are here to use their voices and their concerns, to encourage the ministry to actually adopt a minimum staffing or hours of care of 4.5 up from what we currently have? Do you have any suggestions for that?
Certainly, advocating, writing to the ministers who are responsible, and even the premier. I think this is a time. This is an important time in which the voices of families is particularly important, and I would also suggest are going to be listened to. At least they should be listened to. And similar to, I mean, we can have national standards, but they are exercised and maintained on a provincial level, as we do in the rest of the healthcare system, right? Mm-hmm. And I think that, and so I think that's important. And certainly when we went across Canada and visited the nursing homes in the 4 different provinces, there were differences. There were important differences in. For example, in Nova Scotia, the homes are much smaller. The population is much smaller and more spread out, and so on. So we have to be careful. I guess what I'm saying is we have to be careful we don't, in this process of lobbying for the correct standards, we have to be careful we don't standardize in a way that doesn't reflect the needs of the particular community.
Of course, of course. So you mentioned about other jurisdictions and your research both across Canada or in different places in Canada and internationally. And there's been a lot of talk about inspections and the role of the inspection program in Ontario. How often do other jurisdictions do unannounced inspections? Was that found to contribute to quality of life? And what were any of the consequences or impacts around problems not being corrected readily, for example, within 30 days? Can you speak to the value or the impact of those unannounced inspections?
Yes, they're important. They are important, but it also depends on what's being inspected. I think it's critical. When we were in Germany, they were preparing for an inspection. No, I'm sorry, they just had an inspection. And there were some very interesting issues that the inspectors had found that the administration and the staff were responding to around residents' happiness mostly, anyway, so there were they were having, it was a really interesting conversation, and it was an important conversation that they were having. So what am I saying? I'm saying that inspections need to look at the important things. I think they do need to be not planned, not prepared for. There needs to be surprise inspections. And for example, I would suggest that less important is that every individual is taken to the dining room before 8 o'clock and sitting upright in a chair for breakfast. I would say that is maybe less important than having adequate staff and having what's clearly a good relationship between staff and residents. Mm-hmm.
So just to maybe turn a little bit to the issues of food, and as individuals, food is often one of it's an activity of daily life, but it's also a source of pleasure and it's a social activity. So did you have any thoughts around specifically for food around but the amount of monies that that homes receive for that. So looking especially at the need for or the value of seasonal, fresh ingredients, local food, and the labor required to actually prepare it well to make food, enjoyable for folks. So, and also knowing that Ontario only, gives about $10 a day for the raw food cost. Perhaps other congregate living institutions provide more. But so, can you just talk a little bit maybe about food and what would
Sure.
contribute to life?
Yes, absolutely. And you're right. Food is very, very important, and much more important than only its nutritional value, although that's certainly nothing to be rejected. That's also very important. But we found it was, and it was so very important. And the $10 a day, I would suggest, doesn't seem to be enough, though, at all. The problem with the food also is the so-called cost savings that are made by contracting out these large firms who deliver food to a number of long-term care homes, and it's on it's decisions are made on the cost basis rather than enjoyment or social value basis, and I think that's a problem. As I said, we were so impressed in the number of places we saw where food was prepared on the unit. When we went into nursing homes around the world, members of our research team actually tasted the food. They tasted in every place that we were in. Some of our team tasted the food that residents were eating because we thought that was particularly important to do. And there were places that we went in that the food was incredible. It was it was enjoyable, and it was clear that the residents were enjoying it as well. So we have to be careful, I think, about that we recognize that enjoyment of food, that we don't only move to cut costs in this, which is such an important social and potentially enjoyable experience in a nursing home in long-term care. And I can't emphasize that enough. And that nursing home I went into in Germany, as I said, that was one of the most profound experiences I recall having in this study, and watching residents prepare. I mean, it was a simple pizza with peppers and onions and cheese, etc. And there was a salad to go along with it. But this was very simple food, and yet there was such enjoyment as well. I don't know. Even as the regulation that we see sometimes here, that in order to have a glass of wine, there needs to be a physician's order, or it's otherwise, pretty sharply curtailed. That isn't certainly the case in all long-term care places that we went to in this province or this country, but we did see it in some, and just that level of enjoyment of, if you will, normalcy, having one resident, serving glasses of wine to another. It really did speak to the potential enjoyment that is there.
And that anecdote, but also the one that you used earlier around food in terms of the gentleman with a heart condition and the soy sauce for his meal, really speaks to questions around risk and risk tolerance. Did you come across any decision-making tools homes used or other supports to help them make decisions tied to what might be perceived as a risk, and how that can really be used in planning and just operations of the home, so that we're minimizing the appropriate risks but not taking those pleasures away from people, whether it's food preparation, consumption, or an ordinary glass of wine with dinner.
Well, I think yeah, the way that the most successful places that went about these sorts of approaches did so on the basis of really knowing the resident, did so on the basis of having ongoing discussions between the team about certain residents, about knowing what they wanted, knowing, for example, you have let's say one part-time PSW who goes into a room and sees someone hasn't eaten and removes the tray, but maybe doesn't necessarily know that this is an ongoing pattern, right? Or does that get translated or shared in the appropriate way? So I would say a lot of that. So because you had used the word model, is there a model around this risk avoidance? And I would suggest that rather than there being a specific model, it is about the relationship. It is about knowing the resident. It's about knowing what he or she enjoys and what would make a difference in the lives, right? That ongoingly, and what would encourage not just eating, but enjoyment in eating. So I think that's the key. The key is taking the time. And when you have reports, change of shift reports, it isn't only about who required what medication, how many times someone was incontinent, etc. Those are important. I'm not saying they're not, but it's also got to be about more. It's also got to be about the quality of that individual's life and how they're enjoying that life, and what are the things preventing an enjoyment of that life, and what's going on with the individual's family. What are those relationships like, and how does that impact how this person is? It is that level of knowing that is so very important in order to engage in this risk assessment. Mm-hmm. It's helping someone. We were in places where doors were not locked, right? On the other hand, there was clear knowledge among team members of who might go for a wander, and there was fast move to intercept and to change, time taken to change that person's mind, to redirect, to speak to what the other needs are, to give someone an apple, help them peel, or give them an apple to peel, or depending on what the person has, helping them peel an apple. So that would change their mind a bit on what it was they were agitated about.
Mm-hmm. So I'm going to switch gears a little bit, but maybe it is related to perhaps something that you've mentioned is, what about the role that technology could play in supporting staff and their ability to meet resident needs? And also, did any of the homes you visited have video monitoring, whether in common spaces or in resident rooms? And did the team, your research team, have any thoughts about technology in general and video monitoring cameras in particular?
Do you mean video monitoring on the part of the staff and so on? Like this was
staff
put in place
and families being able to monitor more the residents' personal bedroom area. So might be conventionally called that term like granny cams, or just other surveillance cameras in a resident's room, or for staff technology more broadly, whether it's charting or cameras in common spaces.
Sure. Actually, we did not take on the issue of monitoring within the rooms and so on. That wasn't something we encountered in the homes that we visited. Other types of technology, certainly. For example, some of the accountability monitoring technology, that is the RIMDS, for example, is something that we have written quite a bit about. And on the one hand, recognizing its importance, but on the other hand, asking some critical questions around the amount of time it takes and whether there is an adequate, sort of time use assessment for quality reasons or not. And some of us have written quite extensively on that accountability approach. Certainly the point touch or point click technology that for charting, we have written some on that as well. And once again, although all of these clinical issues, clinical readings, clinical assessments are important, but they are quite reductionistic. Now, there's much, so it seems to be the things that are so closely monitored, and our argument would probably be that there are so many other things in a nursing home being a home and a place for living that are given short shrift because there is so much attention placed on some of these specific clinical numbers. And once again, I hasten to add that it's not that these are unimportant. It's just we think that there needs to be also emphasis placed elsewhere. We did certainly see that point-click care. Again, does it pull the caregiver away from the residents because of that, because of the use of technology? That's something we sometimes wonder about. I'm trying to think of other types of technology that we encountered. I mean, there's certainly the technology of like wheelchairs and things like that. I don't know if that's and the importance of that, but I can't think of any other types of technology, but I may just be having a gap.
May also be something that we're more aware of during this COVID-19 time and the need to use technology to stay in touch. I do want to end on COVID specific in a few minutes, but one interesting question that's come up. Did you see any examples or homes, whether within Canada or internationally, that were tied to a post-secondary institution or other center of learning where students and the associated programs help to address some of the concerns within the long-term care community? So whether that's staffing, social engagement, food, or anything like that. Did you see any promising examples of connections with students?
Yes, yes, actually we did. Well, there was the one home in Germany, but these were students to be caregivers, right? The apprenticeship program and so on. That was one. But we certainly did see other places in which there would be student visits, student volunteers. We found that in a number of places where I guess it was maybe part of community hours. You know, our high school students here also have to have invest so many community hours through high school, etc. And we did see evidence of that occurring, and that was a very positive thing. In general, we found it to be very positive when there was a generational mix. I mean, this it becomes clearly more difficult when it comes to COVID, but generally speaking, we found nursing homes, again, that were definitely situated within a community, and that community could be a daycare or a community center, and there was certainly important interaction between residents and different generations, right? some of them students, and that was particularly important. In general, we have, there is sometimes a problem in, we would argue, building and situating nursing homes outside of communities. I mean, it might be because the land suddenly becomes available and there's a new build, and we certainly did witness that. And the best, or the least expensive land is outside of the city center, or a distance away. And we find that to be highly problematic, as in not promising, just because of that lack of community mix, that decreased ability and opportunity for mixing with different communities, and it's really important to do that.
Okay.
And I think one thing I did want to say back to your last question, I can imagine, of course, we haven't been visiting nursing homes since COVID, but I would imagine there would be a place for that type of engagement, technology enabling engagement between families and residents during a time like a pandemic. I would think there would be a really strong call for exploring what that would look like and how that might be more possible.
It's a very good point, using, combining the tools that we have with the people, it's so important, intergenerational partnerships and relationships to still maintain life and living for folks.
Yes, exactly.
There are homes in Ontario and across Canada that have adopted specific alternative models, whether that's the Eden alternative, greenhouse, or butterfly. Do you think that those are, does your research indicate that that's perhaps the way to go in order to create, a new long-term care system? Or are you perhaps not necessarily recommending specific models, and sort of kind of like what would be behind the recommendation for models versus picking and choosing from different tools?
Yeah. And I think you put your finger on it in that last comment. We did encounter and visited different homes that are part of some of these models that you've suggested. Absolutely. We found that almost all of them had really important aspects of great qualities, and it was about staffing. It was about having the time to spend with residents. It was about teamwork was a big one, and you find that certainly in some of these models. The idea of working together, of not having the strict division of labor, of recognizing and understanding that the importance of living, right? Putting life into years, not only years into life. And so many of these models do offer that, right? But they have quite similar components when you get down to the actual components.
Mm-hmm. So, do you see any conflicts or challenges in matching what your team's highlighting as promising or leading practices versus the Long-Term Care Homes Act? Do you think that the legislation is effective in centering, that real personhood and those relationships, and enabling staff to deliver the care in the ways that you've seen throughout your research?
Well, I think it certainly does provide some safeguards. It has in the past. I would argue, though, and I hasten to say also that a lot of these safeguards, this legislation, have been put in place as a result of a problem, right? So it's in response to a problem. I think, though, that it is important but not adequate. I don't think it speaks to the standards that we need. I think when it comes to, for example, for-profit and not-for-profit differences. I would argue that we need to move towards more not-for-profit, and certainly that's not in the long-term care standards. I would argue around needing 4.5 as a minimum, but not recognizing that given changes like COVID-19, that may be even higher. Right, the 4.5 hours per resident day of care is pre-COVID.
Mm-hmm.
So there has to be, we also have to avoid a situation where a minimum becomes a maximum, which sometimes is an impact of standardization.
Right. So where can we learn more about how, or the differences between how for-profit versus not-for-profit homes operate?
Well, there's a lot that we don't know about how some of the for-profit homes operate. We know some of our research is starting to tell us some of the implications, and some of those implications, as I mentioned, are lower staffing, more transfers to hospitals, more complaints, etc. We know that, and as I said, my colleague Margaret McGregor, has, and also my other colleague Martha McDonald, both have written on some of these issues, as have others. So there is much more research available. If you go on our link, you will find a selection of articles and research that is being done. And I think also, though, I think this speaks to some of the ways in which funding flows to the long-term care homes, and some of the problems in the way that funding, you mentioned the one, such a low amount of funding for food, but also the way in which the envelope funding is structured. I think we need to look at that more carefully. And how would the sector be better funded, more effectively funded
Mm-hmm.
for the type of care we want?
So last couple of questions, and I'm just going to bring us back to the COVID-19 experience, as we're all, living through this pandemic as Ontarians, Canadians, and global citizens. But really, we know that long-term care has been perhaps the most deeply impacted. So a couple questions just to bring us back to that. And some homes are finding that they can't really accommodate physical distancing for things like dining. So residents are having their meals isolated in their rooms. Were there examples that you found or you've come across in terms of how other countries have been able to successfully manage physical distancing requirements during the pandemic in a way that balances safety, but also just quality of life?
Well, short answer, of course, our research in other countries was completed before the COVID-19 pandemic, and we certainly haven't been able to get into any other places since, or places here since. But what we did find is that other places had more surge capacity. They had more space, and that would provide an opportunity. Not all places had more surge capacity, but certainly we were in enough to know that the space that was available would certainly be able to accommodate, for example, a dining experience, that individuals could be adequately separated within a dining room and so still enjoy some of the social aspects of eating, but not be too close. We saw that. Just the ways in which the thinking that has gone into or not into the physical structures and physical environments of long-term care. In fact, one of our bookettes actually is called Promising Practices in Physical Environments in Long-Term Care, Ideas Worth Sharing. And this, again, is one of the booklets that's free. You can download it if you go on our site, or also the Canadian Centre for Policy Alternatives. They have all of those, all of our booklets free for downloading. And that physical environments one, I think your family council members would find very interesting. These are very accessible, written as for the general public, and it holds a lot of important lessons that we could also use for COVID and beyond.
Excellent. We will make those links available. So last question, I want to sort of go back to the idea of reimagining. So many of us are concerned that the post-COVID changes to long-term care may not get us to where we want to be, and that we need increased staffing, and we also need transformation. But we know it's not going to necessarily be cheap or easy. So how do you suggest that our family council members and us as, generally as concerned citizens who care about long-term care work to move this forward? How do we successfully not only reimagine, but transform the long-term care system?
Advocacy. I think it's advocacy. It's linking with others as well. Certainly, this is an issue that's in the news. This is the time, right? It's in the news for very tragic reasons, but it is also an opportunity to turn that around. Advocating to certainly to decision makers, to members of the government, to also members of the opposition, so they can continue the pressure, to and linking with other agencies. You might consider linking with other provider groups, nursing organizations, and so on, who have also been pretty actively lobbying during this time. And not only nurses, there's been so many other groups that have been advocating, and I think it is a time when we say this has been and is unacceptable. Right? This is such a tragic case of devaluing the sector and those who live, work, and have connections with those who live and work there, and we need more. I hope there is a commission of inquiry that is actually effective. Getting standing in that commission of inquiry, I think, would be particularly critical for families and their agencies. I think that's very important. So it is about keeping the pressure up. And it's about doing it locally as well as provincially. Right? I think voices need to be heard. This is unacceptable. As the WHO said, a society is judged on how it treats the most vulnerable of its members, and we haven't done so well.
Well, thank you for spending this part of the afternoon with us and sharing how we as Ontarians, as family members, and as family councils of Ontario can really reimagine long-term care and now can bring those promising practices back to our communities. So on behalf of Family Councils Ontario and all of our attendees, Jacqueline, I'd like to thank you very much for the work you and your team have done to do this research and to bring to light all of those promising practices that we can use to create a better long-term care system and better lives for people living, working, and loving someone in long-term care. So a big thank you to you and your team.
It's been my pleasure. It's our pleasure. Thank you very much to everyone for attending and listening. I appreciate it.
So this concludes this afternoon's session. As you'll see, you can find more resources on the project's website, yorku.ca/RELTC. And for any other questions, please follow up with us at Family Councils of Ontario.